Good afternoon. Welcome to In the Trenches. My name is David Cohen, and I was given the task today to discuss how to approach INR. I'm going to attempt to do this at the spur of the moment. The INR's major use is to measure the efficacy of warfarin. It does have some other uses, but that's its major efficacy. So let's talk about warfarin for a minute. Warfarin is very old medicine, and it's not used nearly as much today. And for a good part of my career as an internist interested in vascular disease and blood clots, this was the medicine that was used. And in a lot of ways, it made my practice very, very difficult because it was very time-consuming. Warfarin inhibits blood clots, and basically, it was used as rat poison. Coumarol was used as rat poison. And they gave it to rats and they bled to death. And some doctor came up with the idea, maybe we could use this to treat blood clots. And actually the acronym warfarin for the trade name is the Wisconsin Alumni Foundation Research for Rat Eradication. So that's what warfarin is. And when I was training in the 80s, it really wasn't until the late 80s that they had to conduct INRs. We got, a patient's prothrombin time and a prothrombin ratio. The thing is, all over the world, they had different reagents used, and what was normal in one lab may not have been normal in another lab. So it all had to be standard, okay? And they came up with the INR, was really the prothrombin ratio to the power of the International Sensitivity Index. That doesn't really matter. But that's the history of the INR, okay? So really to understand this, you have to understand the coagulation cascade. I'm gonna write it briefly, the wall here. So you have the extrinsic pathway and you have the intrinsic pathway. So you go from 12 to 12A, 11 to 11A, 9 to 9A, 10 to 10A, with the cofactor here being factor 8. Okay, 10A, okay, to prothrombin. Cofactor here being 5, prothrombin to thrombin, and thrombin converts fibrinogen to fibrin, okay, and then you have factor 13, which causes stable fibrin. Okay, the extrinsic pathway, you have tissue factor, which activates factor 7, and factor 7A goes here, 10 to 10A. This is where it enters. Okay, that is the coagulation cascade. Now you also have two factors here, protein C and protein S. And whether you clot or bleed, it's a fine balance between antithrombotic and prothrombotic effects. And protein C inhibits factor 5 and factor 8, and protein S is a cofactor for protein C. Okay, now all along these, you have calcium and phospholipids, and these interact with all these factors and the coagulation cascade, and they make them work better. Okay, calcium is actually factor 4. Okay, so here's how warfarin works. Okay, warfarin inhibits the carboxylation of gamma carbon, of gamma carbon, in the synthesis of by inhibiting the enzyme vitamin K reductase. So it affects the vitamin K dependent factors 2, 7, 9, 10. And these factors are rendered inactive because they cannot interact with calcium and phospholipids. They don't work. That's the mechanism. They don't work. It inhibits the enzyme vitamin K epoxide reductase, or VCOR. The other thing that's very important with warfarin is it's metabolized by the CYP2C9. 2C9. Okay? And with this, if you remember your organic chemistry, okay, it's an enantiomer. So you have an R form and an S form. Okay, the R form is less potent, and the S form is more potent. R form less potent, S form more potent. And certain drugs that interact with warfarin are metabolized by the CYP9 syndrome, and they shift it from the R form to the S form. Example would be antibiotics, the most common being Bactrim, okay, which will up this, and it could elevate your INR. Quinolones could do it, erythromycin, other antibiotics. Another big drug that does this is amiodarone. And amiodarone is often used in combination with warfarin in patients with atrial fibrillation. You have to be careful with this. Okay, so where do we use warfarin? We don't use it as much as we used to. Okay, where is it used? For anticoagulation, the two major arenas are AFib and VTE, DVT, PE. With AFib, we're going to use it in patients with valvular AFib. That means they have a prosthetic valve or hemodynamically significant mitral stenosis, which is not as common now because you see this basically with rheumatic heart disease, and that's just not as common. In VTE, you might see this in people with chronic kidney disease who cannot be on the DOAC, NOAC, people who can't afford a DOAC, NOAC, or people with the antiphospholipid antibody syndrome. They do better with warfarin, lupus anticoagulant, antiphospholipid, anticoagulant antibody. So you still use it. Okay, so how do you handle an INR? Overall, the recommendations are 2 to 3. That's where you want the INR. Okay, there's really no great evidence of using of treating for an INR under 2, and it's been studied. It's been studied in VTE and all that. There's really no great indication, even combining with the antiplatelet agent. Prosthetic valves, especially the older ones, sometimes you want the INR higher, 2.5 to 3.5. Or with the antiphospholipid antibody syndrome, you want it on the 2.5 to 3, the higher side. Okay, so, in managing an INR, especially if you're in the hospital or as an outpatient, the issue is, what are you going to do? A patient has an INR and it's very elevated. You need to know the baseline. Now, these change a lot. And how you dose warfarin, part of it's genetic. As a rule of thumb, African Americans, people of African descent, require higher doses. People of Asian, especially East Asian ancestry, require lower doses. Also, a bigger person is going to require more than a smaller person. Those are rules of thumb, but everybody handles it differently. And when you use this, especially in VTE, there's going to be at least a 5-day or maybe longer overall out with low molecular weight heparin or IV unfractionated heparin. So if someone's got an elevated INR, it depends. The two things that are worrisome is the extent of the elevation of the INR and whether they're bleeding or not. If someone's got a real high INR and they're bleeding, that's an emergency. If somebody's INR is 3, 4, 5, and they're not bleeding, you're just going to hold the warfarin. You're going to have to figure out what caused the change in the INR. Now, a lot of it could depend on diet and how much vitamin K they have in their diet. And vitamin K, you have this with green leafy vegetables. And the bugaboo here is you have to be on a constant diet. So either you're going to eat a lot of vitamin K or a little, but it has to be the same amount so you'll get your dose of warfarin. Okay, if somebody has a real high INR, it's over 10, or they have to get a procedure, you need to bring it down. Classically, you're going to give vitamin K. Used to be given sub-Q, now it's given orally. You can give it IV if you want. There's some evidence that sometimes it causes anaphylaxis, but it'll take a period of time for the vitamin K to work. That will bring it down, provided you don't give them a lot of warfarin. And once a patient has a vitamin K in their system, it'll take a while to get it back up. Classically, beyond that, if they were bleeding or just needed to be reversed acutely, and somebody's INR is clearly over 10, you need to treat them right away. And then beyond that, it depends on whether they're bleeding or how quick you need to get it down. Fresh frozen plasma, which is really fibrinogen, factor 8 and factor 13. And they have newer things that you can give, especially in emergencies where you have less plasma, and they may be safer, prothrombin concentrate complexes. And these could be either activated or inactivated. The inactivated case center is probably better because it causes less thrombosis. So this is the INR in general. Let me, wrap this up. You want the INR usually to be around 2 or 3. If someone's on this for a long period of time, you want to make sure there are no safer options, such as like a NOAC or a DOAC. They have to be on a constant diet, and you need to be aware of medications that interact with warfarin, antibiotics, amiodarone, and other medicines that are metabolized by the CYP2C9 system. If somebody's INR is real high or they have to get a procedure, you need to be brought down, but non-emergently, you can give them vitamin K orally. If they can't take it orally, then you give it parenterally. And if they're bleeding or they're at high risk of bleeding, you might have to go to either fresh frozen plasma or prothrombin complex concentrate. It should be noted, the one big thing comparing the NOACs to warfarin, which is also called a vitamin K antagonist, is that the NOACs have less intracranial bleeding, and an intracranial bleed could be a catastrophic complication. Now, there's another thing that needs to be mentioned here, and this is a very important concept, and this is one of the reasons there's a problem with warfarin, and it's called TTR, time and therapeutic ratio. So we talked about it being 2 to 3, that we wanted it to be that. If you do real-world studies, about 60% of the time, maybe a little more, people are in therapeutic ratio. So you have a patient with AFib, and they're not therapeutic, a certain amount of time, they could have a stroke, okay? And if you have somebody with large DVT and they're not therapeutic, they could wind up with a pulmonary embolism. You have to remember about the TTR and to monitor this closely. And with that, I'm going to stop, and we're going to conclude the talk on INR. David Cohen in the trenches. Thank you.